Thank you very much, and thank you for the invitation. It's my first time at the Great Wall Congress. Some of what I'm talking about has already been mentioned by other speakers, including Professor Koji. Uh, these are my disclosures. None of them are actually relevant to this particular talk. So why are we talking about obesity and heart failure? Well, the rates of obesity are rising throughout the world. A lot more in the Western world, but even in Southeast Asia, the rates of obesity are rising, and they're rising exponentially every year. And if we look at what type of cardiovascular disease is most impacted by obesity, it's actually heart failure. So if you look at the graph on the right, as BMI rises, it doesn't really affect the incidence of stroke or even coronary heart disease quite so much, but it dramatically increases the incidence of heart failure. And obesity in itself is certainly an incident risk factor. So this is data from almost 650,000 participants. And so there is a 40% increased risk of heart failure for each 5 kilograms per meter squared increase in BMI. So just to think about, in Australia, we have our rates of obesity are probably as bad as United States. So the average BMI of my heart failure with preserved ejection fraction patient is 34. So not surprising that we're seeing this increased incidence of cardiac failure in association with obesity. And when you do have obesity and established heart disease, even independently, so on the left is dilated cardiomyopathy, on the right is hypertrophic cardiomyopathy, so a genetic condition. But if we look at that, for the patient, with each increase in BMI, there is an increase in left ventricular end diastolic volume, there is increase in LV hypertrophy for each unit BMI, irrespective of the underlying cause of cardiac failure. And that certainly has further prognostic and management implications for these patients. And this is just a very quick show from a COVIA study, so intra-atrial shunt device for management of HFpEF. Just wanted to show some data, having been involved in the study. So in those patients with HFpEF who were obese, they had more risk factors. They were more multimorbid than HFpEF patients without obesity. They had worse fill-in pressures. They had worse LV and LA remodeling. They had more heart failure events overall, and they didn't respond to the shunt device as well. Now, this has been shown by a couple of speakers in this session. I'll just go very quickly through this. What is the pathophysiology of heart failure in the setting of obesity? And it's multi-pronged. There are direct hemodynamic changes of having much larger body mass, so there is increased blood volume, there is increased cardiac wall stress, which leads to the adverse remodeling. Then there are direct effects on remodeling through a variety of cytokines and chemokines released from adipose tissue, leading to increase in LV mass, increase in myocardial fibrosis, increases in inflammation, and reactive oxygen species, which then all have compound effects on mitochondrial function, on intracellular signaling, on intramyocardial lipotoxicity, and then there are comorbidities which further impact all of those things. So diabetes, obstructive sleep apnea, which further increases cardiac stress. That all compounds to increase in inflammation, reactive oxygen species, and fibrosis through various, probably almost all known pathways, all culminating in the development of heart failure. But hold on, we've all heard about the obesity paradox. People who are obese sort of seems to do better. At least that was, we're now looking 22 years down the track, but this was published. So if you actually were cachectic in the presence of heart failure, you do worse than if you were overweight. So this was the complete graph. And you can see that indeed, your cumulative survival, please note, this is HFrEF patients only. There were no HFpEF patients in this study. So in HFrEF, you do best with a BMI of 28 to 32. And that's where the obesity paradox sort of came from. And for a long time, weight loss was not recommended in HFrEF up until about 4 years ago because of this concern in survival. But really, it's a lot more. It's not that obesity is protective. it's probably being cachectic is really, really bad for you. When you enter a state of cachexia and protein and muscle catabolism, that's really more of an indicator that you're at the very end of your journey, rather than the obesity per se is protective. There is also a selection bias. Healthier patients were more affluent patients were probably able to have better diets, had a slightly higher weight, more likely to participate in trials. So it is conflicted data. There's probably no real obesity paradox. It only is an issue if you're cachectic, you will do worse. And that certainly is true in HFpEF as well. Now, I'll briefly go through some of the data that actually, now that we have this problem of obesity and its rise, and what can we do about it? Well, the first thing that has been trialed for many, many years and decades is physical activity and exercise. And look, exercise has a host of beneficial effects on cardiac function, from lung capacity, reduction in dyspnea, improvement in endothelial function, improvement in blood pressure, renal function, reduction in adiposity, improvement in lipids. So certainly exercise is extremely important. However, in heart failure, sustained exercise is very challenging. Patients really do not achieve it outside of dedicated clinical trials, and overall effect is actually quite modest. Half a kilo weight loss, couple of kilograms of weight loss, most patients put it back on after the trial is finished, and it has not really shown a sustained effect on mortality or significant effect on heart failure hospitalizations. Now, when we combine it with diet, so you can see, I'll just concentrate on the graph on the upper right. So this was a 2x2 factorial design control versus exercise versus diet plus exercise. The graph shows VO2 max, so cardiac functional performance. Exercise and diet both had modest effects, pretty similar to one another. Combination is better. Once again, when you combine diet and exercise, we know the compliance goes down outside of clinical trials. We as humans are very bad at restricting things that we enjoy, being nice food, and we're not very compliant when we need to exercise when the weather's cold or rainy or whatnot. So effects are modest. Now, bariatric surgery. You don't need to be compliant. Once the Roux-en-Y bypass has been done, can't be undone. So this study, so it was one of the largest, 5,300 patients versus 5,300 controls, not randomized, of course, not blinded, can't do those things with bariatric surgery. But essentially, you see that bariatric surgery had profound and statistically significant effect on incidence of heart failure, atrial fibrillation, combination of heart failure and AF, and mortality. It's important to remember, of course, these patients to get bariatric surgery were not just overweight or obese. They had to have morbid obesity, BMI of 44 or greater. So not surprising, they also had quite a profound benefit because they had such a low point to start off with. But very effective therapy, expensive, not universally available, permanent, associated with surgical risks and other malabsorption in certain cases, other gastric side effects. A lot of studies, most of them are small, all show some degree of benefit depending on what the primary outcome was, whether that was cardiovascular mortality, improvement in exercise, or improvement in functional status. But now, medical management, that's the latest craze. So this study has been shown by Professor Koji already, a STEP-HFpEF program with semaglutide. So they had a diabetic arm and a non-diabetic arm of patients with heart failure, statistically significantly positive, but they had soft outcomes. So the outcome was body weight loss and KCCQ improvement, secondary outcome 6-minute walk test. Not surprisingly, there were improvements across both primary and secondary outcomes with semaglutide. They, Novo Nordisk was very happy. They said, there's also, because the study is positive, we'll look at the outcomes and look on semaglutide, the heart failure, the cardiac outcomes are so much better. Just have to remember it's 30 events versus 8. They're tiny numbers. So it's very hard to actually say, it's definitely significant. The signal's there, but in a study of 1,500 patients, looking at 8 events is very hard to be sure that that's real. There's certainly been improvements in inflammation measured by CRP and surrogate measures of heart failure, looking at changes in NT-proBNP. Now, the SUMMIT trial was specifically an obese HFpEF, is the trial of Mounjaro, tirzepatide, so Eli Lilly product. So this was specifically looking at heart failure. So they had patients with HFpEF class 2 to 4, 730 patients, and they looked at, they had to have BMI of above 30, so not morbidly obese. 6-minute walk test was one of the primary readouts. I'll skip that. So the cumulative incidence of CV death or worsening heart failure was significantly improved with tirzepatide, and there were improvements in KCCQ as well. So this was a dedicated HFpEF study looking at actual cardiovascular outcomes rather than the surrogate things like 6-minute walk test. Tirzepatide also reduced CRP, troponin, improved GFR, renal function, reduced NT-proBNP, and improved LV mass on an MRI sub-study. So certainly we're now seeing a stronger signal for those medical therapies. Obviously, GLP-1 receptor agonist, tirzepatide also has a GIP effect as well. Now, the SELECT study was the semaglutide cardiovascular outcomes trial. Now, this was not a dedicated heart failure study. They had some heart failure studies, but the patients were just established CVD, BMI above 27, and they actually excluded severe heart failure. Biggest heart failure study, over 17,000 patients. Now, they've done a post hoc analysis looking at HFpEF patients and HFrEF patients out of that whole cohort. You can see 2,200 HFpEF, 1,300 HFrEF patients, and they reported there was an improvement in heart failure composite, but you can appreciate that the confidence intervals in both cases cross unity, so not statistically significant. There's a signal that probably something's there, but a more definitive CVOT trial is needed to be sure. And this is just to show what is the weight loss with different modern drugs, and you can see GLP-1 receptor agonists are there, then there are surpassing amounts of tirzepatide, and then there are triple combinations which seem to have an even greater weight loss, and potentially, although there is no real data yet, maybe a greater cardiovascular benefit. Now, in the interest of time, I'll just go quickly. Other speakers have covered some of the mechanisms of action of how tirzepatide or semaglutide might improve things. There is heart-brain axis that gets involved, so where there is stimulation of anorexigenic stimuli, there is actually improvement in sympathetic and parasympathetic drive affecting the heart. There are direct effects on cardiomyocytes and substrate metabolism, in paracrine effects from adipose tissue, pericardial and epicardial adipose tissue. There are endothelial functional effects, effects on skeletal muscle. We know that skeletal muscle health actually has an impact on myocardial muscle health. So there is a whole host of beneficial mechanisms, many resulting in reduced systemic inflammation. Weight loss in itself is better for cardiac fitness. If you lose weight, you can exercise more, you feel better, you look after yourself better. So all of those reduce the risk of worsening heart failure. This is just to show that it's the only head-to-head trial. Which one gives you better weight loss, tirzepatide or semaglutide? Tirzepatide came out on top by about 7% better weight loss with a combination GLP-1 GIP drug, GIP drug versus pure GLP-1. And that has resulted in this statement published just 4 months ago. So it's an ACC scientific statement on management of obesity in adults with heart failure. And you can see they say, look, behavioral changes, diet and exercise are good if you need to lose a little bit of weight. But the caveat is limited data in heart failure. Sustained improvements are hard to know. Anti-obesity medications got the biggest stick, especially with tirzepatide having the definitive cardiovascular outcome trial in heart failure. And so that got a specific mention. And obviously bariatric surgery for those who are morbidly obese and has actually very strong data. Now, I know I've got... So major unanswered questions. Do you have to treat with those medical therapies lifelong? What about when I was seeing children and young adults, with obesity? Do we give them for 70 years those drugs? What do we do? Is there loss of cardiac mass with those therapies? Because we know there is loss of skeletal muscle, and conclusive data, especially in HFrEF, is still lacking. So I'll stop here. So those drugs certainly improve quality of life, do weight loss. How much they actually do for definitive cardiovascular outcomes and heart failure, the data is still limited. Thank you very much.